Hello guys, today we start talking about the lymphadenitis or lymphadenopathy and lymphangitis. Not really important topic, how I think, but it is really interesting topic. Why it is not really important? Because not always we see these problems in the patients, and more often it is not a problem at first problem. Yeah, it is a symptom of some disease. The lymphatic system is a complex component of the immune system involved in the filtering substance in the body. Lymphocytes are the integral agents involved in searching for target proteins and travel through lymph nodes, which are diffusely placed throughout the body. Lymphadenopathy is a term that refers to the swelling of lymph nodes. Lymph nodes are small glands that are responsible for filtering fluid from the lymphatic system. Please you remembering that lymph nodes, it is a small glands. They are divided into sections known as follicles, which are subdivided into B zones and T zones, which represent the base location of lymphocytic maturation. Abnormal proliferation of lymphocytes may be a result of inflammation, infection, or malignancy, and thus clinicians must perform a detailed history and physical to screen for lymphadenopathy. When inspection for lymphadenopathy, one should carefully examine all pertinent anatomic regions, including the neck, supraclavicular, axillary, and inguinal regions. In general, the size of a normal lymph node in the adult population should be less than 1 cm. However, there are exceptions to this rule. Lymphadenopathy, while pertinent, may be non-specific. There are several potential causes of lymphadenopathy, ranging from infectious, autoimmune, malignant, and lymphoproliferative. There is a wide range of infectious etiologies, including bacterial, fungal, viral, mycobacterial, spirochetal, and protozoal organisms. Autoimmune disorders that may contribute include but are not limited to sarcoidosis, amyloidosis, systemic lupus erythematosus, rheumatoid arthritis, and eosinophilic granulomatosis with polyangiitis. Malignant disease like lymphoma, leukemia, metastatic cancer, and head and neck cancers are also common causes of lymphadenopathy. Lymphoproliferative disorders such as lymphagocytic lymphohistiocytosis can also manifest with an enlargement of lymph nodes. Lymphadenopathy can be localized or diffuse. About 75% of most lymphadenopathies are localized, and about 50% of those occur in the head and neck regions. Generalized lymphadenopathy, which involves two or more non-contiguous regions, is reported to occur in 25% of lymphadenopathies. Elucidating the etiology of lymphadenopathy can be challenging. A thorough history and physical exam are one of the most important steps in determining the underlying cause of lymphadenopathy. Etiologies can be determined based on lymph node groups. Submental and submandibular lymphadenopathy commonly is infectious in a region, often presenting with viral prodromes. Posterior cervical lymphadenopathy can arise from localized bacterial and viral infections as well as lymphoma. Axial lymphadenopathy can also be related to lymphoma or breast malignancy, but can be involved by infections such as cat stretch disease. It when we have the problem with lymphatic system in a moment when the cat scratching the patients. Lastly, inguinal lymphadenopathy can be impacted by local sexually transmitted infections, lymphoma, and pelvic malignancies. A majority of patients with lymphadenopathy will have a benign etiology. Age is an important factor in characterizing the epidemiology of lymphadenopathy, and thus can be divided into children and adults. Children more commonly appear to have benign cause of lymphadenopathy. To better understand this, a study completed by Knight received 239 children who underwent a peripheral node biopsy and found that the most common etiology noted was reactive hyperplasia of unknown etiology, followed by granulomatous infections, cancer, and dermatopathic lymphadenopathy. Adults also appear to have low prevalence of malignancy. To further characterize this, a study was completed in a family practice setting where only 3% of 249 patients with lymphadenopathy underwent biopsies. Of these patients, no one was found to have a debilitating illness. A Dutch study also revealed that of 2,556 patients that presented with unclear lymphadenopathy to their family physicians, 10% were referred for a biopsy and only 1% were found to be related to malignancy. These findings are mirrored by two case series completed in family practice departments within the United States that demonstrate that 0 of 80 patients and 3 of 238 patients had malignant causes of lymphadenopathy respectively. It is important to remember that endemic regions such as South Africa or India have increased rates of lymphadenopathy due to tuberculosis, parasitic infections, and HIV. Lymph nodes are part of the reticular endothelial system, which includes monocytes of the blood, macrophages of the connective tissue, thymus, spleen, bone marrow, bone, mucosa-associated lymphoid tissue of visceral organs, lymphatic vessels, and lymphatic fluid found in interstitial fluid. Lymphatic fluid moves throughout the lymphatic system, transitioning from the organs to lymphoid capillaries, lymphatic vessels, and finally lymph nodes for foreign antigen filtration. Foreign substances are presented to the lymphoid cells, which lead to cellular proliferation and enlargement. Under microscopy, cellular proliferation in lymphoid follicles may be identified as several meiotic figures. As lymphatic capsules stretch due to increased activity, patients may experience localized tenderness. The development of B cells originates from pluripotent stem cells from the bone marrow. B cells that successfully build their immunoglobulin heavy chains migrate to the germinal centers to allow for antibody diversification by somatic hypermutation. B-cell lymphomas are believed to be a result of alternations in somatic hypermutation and chromosomal translocations. The development of T cells also begins from pluripotent stem cells, which mature within the thymic cortex. While in the thymic cortex, T cells begin specific rearrangements at the T cells receptor. It is understood that chromosomal translocations at the level of T cell receptors lead to T cell lymphomagenesis. Lymph nodes follicle necrosis may occur as a result of many different conditions, be it inflammatory, infections, or malignant. The predominance of neutrophilic infiltrates suggests bacterial infections, while lymphocytic predominance may suggest viral infection. However, clinicians must remember that etiologies may vary. Lymphomas, leukemias, tuberculosis, or even systemic lupus may be more appropriate diagnosis in the appropriate clinical context. Histology of lymph nodes can vary when there are endogenous insults. Histology can provide further information regarding the cause of lymphadenopathy when etiology is not clear during initial history taken, physical examination, and laboratory evaluation. Below is a list of common causes of lymphadenopathy with associated histological findings. Bacterial lymphadenitis, predominantly neutrophilic infiltrate, can be found within the sinus and medullary cords. Follicular hyperplasia can be seen as well. Viral lymphadenopathy, infiltration by macrophages and lymphoid hyperplasia. Necrosis can be seen in those who are immunocompromised. Sarcoidosis, non-casein granulomas that replace the normal architecture of the lymph node. Non-Hodgkin lymphoma, there is partial or widespread loss of the lymph node by a single cell lineage. Lymphoid cell can either proliferate in a disorderly manner or as those that mimic follicular central structures. Hodgkin lymphoma can be classified by the histological appearance. Note below. These histological types are listed in order of most common to least. We have nodular sclerosing, mixed cellularity, lymphocyte rich, and lymphocyte depleted. History and physical. History and physical must be completed in a systematic form. One must always remember all components of a complete history and physical examination. First of all, history of presenting illness, location, pain if so, intensity, quality, onset, precipitating factors, elevating factors. Second, review of systems. This should include a system-based review of all organ systems, including constitutional system, fever, chills, night sweats, changes in weight, fatigue. Past medical history. It is imperative to know the patient's previous medical history, as this could clue into the reason for lymphadenopathy. HIV, AIDS, remote history of non-Hodgkin lymphoma. Medications. Some medications can cause reversible lymphadenopathy. Cephalosporins, phenytoin. 5. Social history. It is vital to know living conditions, chemical exposure, use of alcohol, tobacco, recreational drugs, pets, animal exposures, recent travel. 6. Sexual history. It is pertinent to know the number of sexual partners, sexually active with males, females, or both. Use of protection, history of sexually transmitted infections and partners with known sexually transmitted infections. Surgical history. Inquire about which surgeries and when they occurred, how soon the lymphadenopathy occurred. And 8 is family history. It is imperative to know if a family history exists of cancer. Physical examination. We need to check the vital signs, temperature, blood pressure, heart rate, respiratory rate, oxygen saturation, all of significance to help determine if the patient is hemodynamically stable. This can help differentiate sepsis from benign conditions. A head-to-toe exam must be conducted, including inspection of the head, ears, nose, throat, and thyroid gland. Auscultation of lungs, heart, and palpation for splenomegaly and hepatomegaly. A thorough inspection should be done of the skin, palpation when necessary, looking for raises, lesions, nodules. When palpation lymphadenopathy, one must keep in mind location, size, firmness, and pain. Anterior cervical lymph nodes are superior and inferior to the sternocleidomastoid muscle. Posterior cervical lymph nodes are posterior to the sternocleidomastoid muscle. One should also inspect for supraclavicular axillary and inguinal lymphadenopathy bilaterally. Local lymphadenopathy suggests a more localized disease as compared to widespread lymphadenopathy. Cervical lymph nodes and axillary nodes are atypical if more than 1 cm as compared to supraclavicular more than 0.5 cm and inguinal nodes more than 0.5 cm. Generally, if lymph node is readily mobile, it is less concerning for a malignant condition. Pain can be a sign of inflammation, an acute reaction to an infection, and is less concerning for a malignant process. Laboratory evaluation, imaging, and lymph node biopsy we can use for evaluation. Laboratory evaluation blood chemistries including complete blood count with differential, complete metabolic panel, lactate dehydrogenase, fungal serologies, laboratory evaluation of syphilis, HIV, CMV, EBV, HSV, HBV, quantiferon for tuberculosis. Imaging CT of the chest, abdomen, and pelvis can be used to further substantiate the location of lymphadenopathy, pattern, and size. This can also get a biopsy if needed. And biopsy. The need for lymph node biopsy depends on the etiology of lymphadenopathy. An excisional node biopsy is the gold standard for diagnosis. Treatment differs depending on the etiology of lymphadenopathy. Simply put, the following generalizations can be made. First of all, we start with any types. If we know about the malignant, we do the surgery, radiation therapy, chemotherapy. If we know about autoimmune, we do the immune therapy, systemic glucocorticosteroids. If it is infections, we start with antibiotic therapy, antiviral therapy, or antifungal therapy. And if we know that the reason is a medication, we discontinuation of medication with reevaluation if it is necessary. The variability in cases of lymphadenopathy can often present diagnostic changes to clinicians. To reduce confusions and to improve diagnostic accuracy, it is important to obtain a thorough history and physicians create a set of differentials and organize them in accordance with their representation. Cause of lymphadenopathy: malignant, autoimmune. Malignant. If the history and physical examination are consistent, lymphadenopathy may be concerning for diagnoses like metastatic breast cancer, Kaposi sarcoma, leukemias, lymphomas, metastatic disease, malignant disorders of the skin. Autoimmune. Several conditions that are characterized by a highly active immune system may result in lymph node abnormalities, including dermatomyositis, Kawasaki disease, rheumatoid arthritis, sarcoidosis, Sjögren's syndrome, Still disease, systemic lupus erythematosus. Infectious. Many different infections can contribute to benign changes in the lymph nodes. Healthcare providers may consider several differential subcategories of infection, including bacterial, viral, and other. Bacterial: brucellosis, cat scratch disease, bacterial pharyngitis, syphilis, tuberculosis, tularemia, typhoid fever. Viral: cytomegalovirus, hepatitis, herpes simplex, HIV, mononucleosis, rubella, viral pharyngitis. Other: bubonic plague, blastomycosis, coccidioidomycosis, cryptococcus, histoplasmosis, toxoplasmosis. Medication. Often medical therapies may include the benign growth of lymph nodes. These therapies include but are not limited to allopurinol, atenolol, captopril, carbamazepine, cephalosporins, gold, hydralazine, penicillin, phenytoin, primidone, pyrimethamine, quinidine, sulfonamides, and Salendec. The aforementioned cause may be subdivided into mnemonic MEIM, which may help as a useful memory for recall of the vast amount of differentials that may contribute to lymphadenopathy. These differentials lead to changes in lymph node size and or consistency and require further investigation with history, physical examination, and diagnostic testing. Staging is a process in oncology that allows healthcare providers to determine the extent of disease burden from its primary locations. It should be known that malignant lymphadenopathy can occur from both primary lymphomas or from metastatic cancer. Most but not all cancers use the tumor, node, and metastasis staging system (TNM). A tumor refers to the primary involvement by the neoplasm and the depth of involvement. Node describes the local lymph nodes that are involved by the disease process, and metastasis defines distant sites of involvement. The staging of non-Hodgkin and Hodgkin lymphoma is based on the Lugano classification, which is based on the Ann Arbor system. There in the picture you see these stages, but I won't show you a text. Stage 1 lymphoma found in one lymph node or in only one lymphoid organ. Stage 2 lymphoma is found in two or more groups of lymph nodes on the ipsilateral side of the diaphragm. Stage 3 lymphoma involvement bilaterally in reference to the diaphragm. Stage 4 lymphoma has metastasized to one organ beyond the lymphatic system. General lymph node enlargement in younger populations tends to be benign and usually related to infection. There are exceptions to the rule, particularly if the patient's history and physical are concerning for chronic infection, malignancy or autoimmune conditions. Other risk factors that may be poor prognostic indicators include, but are not limited to, advanced age. Length of duration of lymphadenopathy more than 4 weeks is concerning, generalized lymphadenopathy, male sex, lack of resolution of node size, and systemic signs such as fever, night sweats, weight loss, hepatosplenomegaly. Complications. While lymphadenopathy itself may not lend itself to complications, unaddressed lymphadenopathy may lead to worsening progression of an underlying condition, the most concerning of which is sepsis or metastatic cancer. For lymphadenopathy related to autoimmune disorders, progressive autoimmune disease may lead to cancer or dysfunctional immunity, which may lead to significant morbidity and mortality. Lymphangitis is an infection of the lymph vessels channels. It is a complication of some bacterial infections. Yeah, we start talking about lymphangitis, and maybe you see this red way in the arm. It is a lymphangitis, inflammation of lymphatic channels. The lymph system is a network of lymph nodes, lymph ducts, lymph vessels, and organs that produce and move a fluid called lymph from tissues to the bloodstream. Lymphangitis must often result from an acute streptococcal infection of the skin. Less often it is caused by a staphylococcal infection. The infection causes the lymph vessels to become inflamed. Lymphangitis may be a sign that the skin or soft tissue infection is getting worse. The bacteria can spread further into the blood and cause life-threatening problems. A mere function of the lymphatic system is to resorb fluid and protein from tissue and extravascular spaces. The absence of a basement membrane beneath lymphatic endothelial cells affords the lymphatic channels a unique permeability, allowing resorption of proteins that are too large to be resorbed by venules. Lymphatic channels are situated in the deep dermis and subdermal tissue, parallel to the veins, and have a series of valves to ensure one-way flow. Lymph drains were efferent lymphatic to regional lymph nodes, and then by efferent lymphatics to the cisterna chyli and the thoracic duct into the subclavian vein and venous circulation. Lymphangitis due to infection most commonly develops after cutaneous inoculation of microorganisms that invade the lymphatic vessels and spread towards the regional lymph nodes. Organisms may invade in lymphatic vessels directly through a skin wound, abrasion, or as a complication of distal infection. Lymphangitis can also be caused by inflammation of lymphatic vessels without an infectious cause. Symptoms: fever, chills, enlarged and tender lymph nodes, usually in the elbow, armpit, or groin. General ill feeling, headache, loss of appetite, muscle aches, red streaks from the infected area to the armpit or groin, throbbing pain along the affected area. More often, I see the lymphangitis in the arms. Thanks for your attention and have a nice day. Bye bye, guys.